Diraj, the other aspect of AF management that perhaps isn't given the same focus is the issue of either rate controlling or rhythm controlling patients. Historically, we have, in the recent past anyway, tended to accept AF in the vast majority of our patients very early on and deploy an initial rate control strategy, either with beta blockers or rate limiting calcium channel blockers like diltiazem or verapamil, sometimes even adding in digoxin. And of course, there is no reason why this rate control strategy cannot be safely and appropriately overseen in primary care. Now, in paroxysmal AF, particularly when symptomatic, antiarrhythmic drugs such as flecainide are often advised as a first-line strategy. But Diraj, of course, there is an effective intervention in AF. You've mentioned catheter ablation, which can be used in both persistent and paroxysmal AF. So my first question to you is, has the AF rhythm control management paradigm shifted with recent evidence? And could there be a case for assessing patients for catheter ablation much earlier in the trajectory?
Well, there's absolutely no doubt that there's been a paradigm shift in this field in the last few years. We've had some pivotal randomized controlled trials that have been published in the last couple of years, which have really moved the field forward. First of all, I would like to draw attention to the EAST AF trial, which studied patients with new onset atrial fibrillation diagnosed within the last 12 months, who were randomized to either rhythm control, which included catheter ablation, but could also include antiarrhythmic drugs, or rate control. And the patients were followed up to 5 years. And for the first time ever, it was clearly shown that patients who were randomized to rhythm control did a lot better in terms of not only improved quality of life, but in terms of hard outcomes, such as cardiovascular hospitalizations, such as stroke, such as all-cause mortality. So this has finally proven to a lot of us what we felt was intrinsically going to be the right way forward, intrinsically try to restore normal sinus rhythm. Now, in the past, the negative results of the rhythm versus rate control trials were largely dependent on the fact that all anticoagulation was not standardized in those trials. A lot of the patients who were randomized to rhythm control, they had a cardioversion and their warfarin was stopped. Whereas in the EAST AF trial, every patient was continued oral anticoagulation based on the CHAS-VAS score, irrespective of whether they were randomized to rhythm or rate control. And once that was standardized, rhythm control strategy had a chance to shine over and above rate control.
Yeah.
Now, in answer to your second question about catheter ablation, there have not been one, not two, but three randomized controlled trials published back to back within a 6-month period, which have studied the role of catheter ablation for AF as first-line treatment as compared to drug therapy. And all three of those trials have shown that catheter ablation is superior to drug therapy in terms of improved quality of life, improved freedom from atrial fibrillation, and also improved freedom from hospitalization from atrial fibrillation. We published a meta-analysis of all of these trials recently in the heart, and we showed that there was unequivocal evidence now that for patients with new onset atrial fibrillation, rhythm control with catheter ablation is superior to rhythm control with drug therapy.
Wow, so that's a real paradigm shift, isn't it? So, Diraj, a lot of our patients with atrial fibrillation, certainly in primary care, are sort of elderly patients. Is age ever an absolute barrier, or should we still be considering referral irrespective of age, or going with biological age, for instance?
I think you've hit the nail on the head. Not every 80-year-old patient will be alike. So we tend to go more on biological age or physiological age rather than just the chronological age. It depends very much on patients' quality of life, their activity levels, their presence or absence of other significant comorbid conditions. I do not use age itself as a criterion anymore. I've offered catheter ablation to patients as old as 90 years of age. There's absolutely no reason why we should have an ageist policy. And indeed, if you look at the latest guidelines on atrial fibrillation management, they make absolutely no mention of having an upper age cutoff.